Does that look good? Okay. All right. So
It's okay.
Alex, don't forget they're radiologists. Even if there is some confusion, they can understand the image. So, but you
okay.
have a pretty good slide.
All right, great. So the first question will come up, and again, in terms of our role as radiologists, oftentimes this is an important issue, is the appropriate use of the technology. So when should we image patients with seizures? So the age of onset of seizures will determine the role of imaging as well as the way we image. And I'll get into this a little later, but obviously the childhood onset of seizures, young adult onset of seizures, and adult onset of seizures have different expectations in terms of what pathology we look for and how we image the patient. And I think that one thing that I've seen in my own practice is that the overuse of imaging, the patient who is, 30 years old, is at a party, drinks too much, has something that resembles a seizure, comes to the emergency room, and they order, an elaborate MR evaluation of the temporal lobe looking for a seizure focus. That's really not appropriate. So we're looking at patients who have epilepsy, but epilepsy meaning seizures over a long period of time. I think strictly speaking, the diagnosis of epilepsy can be applied with 2 or more seizures, but really we're looking for patients with long-standing seizures. And then obviously there's not really a great role for imaging in patients who have an excellent response to medication. An individual that goes on anti-seizure medication hasn't had a seizure in 10 or 15 years, there's really no role for imaging because there's no intervention that would be recommended with that success of medication treatment. And then you want to think about what is the goal of imaging. That's really the important thing, is that is the expectation that if we find a seizure focus, that we would treat that patient. This is mostly in young patients. And then in older patients, the goal of imaging may be to identify a serious underlying pathology, such as a cause of stroke or brain neoplasm. Now, the choices of imaging are limited in the sense that MR is the primary means of evaluating patients. Now, I know that a young adult who has their first seizure often comes to the emergency room and gets the CT scan, but the intent with the CT scan is to identify some urgent finding like hemorrhage and the like, and not effective in identifying most of the pathologies that we'll talk about today. So unlike some of the lectures you're going to see, this is going to be pretty much MR all the time. We look at the cortex and the medial temporal lobe. These are high likelihood spots for a seizure focus. Obviously, we're going to be looking for tumors, but we'll also look for malformations of the brain, such as schizencephaly, cortical dysplasia, and abnormal neuronal migration. So it's a long shopping list of things you look for. But again, this goes back to Hughlings-Jackson, 1860, who argued that seizures were due to an excessive, uncontrolled discharge originating in the cerebral gray matter. And pretty much that's the way we still think about it. Now, when should I get high resolution imaging? Now, this is obviously not, as I indicated, not for patients who have responded to medication. These are for patients with intractable epilepsy. And in Dr. Jack in 1993 indicated that, that patients with complex partial seizures, the origins frequently are in the temporal lobe, and thus the interest in temporal lobe and temporal lobe anatomy. Now the approach is a little different in patients with adult onset. When I say adult onset, I mean 40s and older. That in these patients, you really are not looking for a congenital malformation. You're not looking for or seizures of a temporal lobe origin. Typically, you're looking for something like a stroke, sequela of previous trauma, and so on. And in these cases, you want to use contrast, because you could have a metastatic focus that could be the source of seizures that may be more evident if you give contrast. So as we look at this slide, which gives you a sense of how the cause of seizures changes in different age groups. As we go into this 30 and older group, we see that vascular disease becomes more common, brain tumors are more common, whereas in the pediatric age groups of 10 and below, this is where we're looking for perinatal injury, metabolic, congenital malformation, and so on. So again, your approach to imaging and with the sense of asking yourself, what is it that I'm looking for, changes with the age of onset of seizures. So why is this focus on hippocampus? Number one, it is often the source of abnormality in patients with drug-resistant epilepsy. And if you identify an abnormality in hippocampus, in a sense, if we can find and localize an epileptogenic focus to the hippocampus, there is a high likelihood that that patient will respond to surgical treatment. And that is, for these patients, life-changing. I remember a patient we had who had these terrible burns that he had incurred because he was a professional cook, and he would have seizures while he was in the kitchen and would have these burns from the stove. So again, the ability to drive, the ability to have a career are powerfully impacted by effective therapy. Now, you'll see this listing CA and these sectors 1, 2, 3, 4. We won't get into the meaning of these different sectors, but I think this is a nice anatomic illustration that shows you the layers within the hippocampus. It's a very complex structure and with high functional significance. Now, the CA is actually an abbreviation for this core nu ammonis, which has an interesting history in that the ram is associated with the Egypt god of Amun. And the term comes from the sense that pathologists, when they would section the brain and look from the lateral temporal lobe side, they could see the bulging of the hippocampus into the medial temporal horn, which resembled the ram's horn, which is the origin of the name. So when you're looking for this cause of seizures arising from the temporal lobe, the features that you should be looking for in the hippocampus is the hallmark really is the small hippocampus with high signal intensity on T2 weighted imaging. There are other findings that you're going to look for. One is the loss of normal internal structure. I'm not sure in your countries if there's an equivalent of a jelly roll, but the idea that it has this kind of rolled appearance with layers, and you want to look for on high resolution imaging the internal structure of the hippocampus. And this ability to visualize the brain, as you could imagine, is improved with 3 Tesla or high field imaging. And that is the preferred way to look at the brain of patients with intractable epilepsy. And then this other feature, thinning of the collateral white matter, is not really useful in of itself. It's one of the other features that you look for that might support cases where, and you will see cases like this where the findings are really quite subtle. This is, I'm old enough to remember the origins of MR. This is the image quality we would get in the 80s. And this is one of the patients we had early on with mesial temporal sclerosis. And here you can see the normal hippocampus. Notice the temporal horn sort of drapes over the hippocampus. There should be no gray matter lateral to the temporal horn. If you look at the corresponding location on the left side, here you see the temporal horn, and you don't see this gray structure, which indicates that the hippocampus is atrophic on this side. Now, this is a more modern set of images, and this is the wonderful ability of FASP Echo T2 to show this excellent tissue resolution. And so as we go from posterior to anterior, you can see again the hippocampus here lying just medial to the temporal horn of the lateral ventricle. And here we see on the other side, notice we have white matter along the lateral border of the temporal horn. And here you can see that jelly roll appearance of the hippocampus on the patient's left side, and a little blurring of the anatomy on the right side, which, as you can see, is smaller than the left side. Now, a little bit of asymmetry is acceptable, but this is beyond what you would expect to see in terms of normal variation. So this is a case of unilateral, abnormal signal, loss of internal structure, and small size of the hippocampus. And so on these images, you would be able to make the diagnosis of mesial temporal sclerosis. And if this matched up with the electrical studies and so on, this would give the treating physicians a target for therapy. So this is a kind of a classic case of mesial temporal sclerosis. Notice the smoothing of the anterior hippocampus. Again, this is what you expect to see in mesial temporal sclerosis. There's one other feature here that we'll get into is you want to look at the extra hippocampal findings. And here you see the mammillary body on the left, and the mammillary body on the right side is smaller. So we see, again, small hippocampus, abnormal signal in the hippocampus, abnormal structure of the hippocampus. Now, another feature you can look for is in the anterior hippocampus. There is normally this wavy appearance of the hippocampus, and this section gives you a little element of it, but smoothing of the anterior hippocampus, as you see in this case, especially along with some abnormal T2 prolongation, is commonly seen in patients with mesial temporal sclerosis. Here on this image, we happen to be through the anterior portion of the fornix. These are the postcommissural fibers going to the mammillary bodies, which here you can see are symmetric in size. So the extratemporal lobe findings in mesial temporal sclerosis are this loss of medial temporal lobe structures, which include the hippocampus and the subiculum, lead to the loss of afference to the limbic projections. And these can result in the small fornix or mammillary bodies. Now, that's a little complicated language, but just be aware of this limbic system, which hippocampus is just one part of. And this is the Papez circuit. And this goes, you see, travels through the parahippocampal gyrus, the hippocampus. Projections go then to the fornix and the mammillary bodies and actually wind their way back to the cingulate gyrus. So this is loss of the fibers or shrinking of the fibers of the Papez circuit as a result of loss of tissue in the medial temporal lobe. And I'm, just can sort of speak from my looking back in my old days. This is 93. This was actually a medical student I was working with, and this was the first publication that identified this asymmetry of the mammillary body in epilepsy. Here you see the absence on the right side. This is a patient, just to illustrate the small fornix you can see on this side and small mammillary body on this side in a patient with mesial temporal sclerosis. Now, when you look at this image, I can tell you when I started out in my career in neuroradiology, this was a relatively new concept, and it's the sort of thing that amplifies this saying that I've heard in radiology, and it goes, "I'll see it when I believe it," in the sense that this observation is really quite difficult if you're looking at images without history and without pre-knowledge of all the findings of mesial sclerosis. But once you learn the patterns and if you have the appropriate history, you can be quite successful in making this diagnosis, which is critical for the patients. So you're going to look in deeply into the temporal lobe with as high quality imaging as possible, preferably in a plane perpendicular to the long axis of the hippocampus. And you're going to look for these extratemporal findings, not as primary features, but as supportive features of abnormalities that you already see in the temporal lobe. So we're going to go to, let's see if I can pull this up. Okay, now I want you to look at this image. And I'm only going to show you one image, and obviously I would pick a representative image, and this is our case one. And I want you to respond to this poll. Do you think this patient has mesial temporal sclerosis? And if you do, which side is it on?
Alex, when you ask side, you mean the patient's side, is that correct?
Correct. Yeah, I probably should have been clear about that. Thank you, Vikan. So yes, obviously from a convention of imaging, this is the patient's right side, this is the patient's left side. Any more responses? I'd like to see at least 75%. And again, don't be shy, because I'm not keeping track of this. No one can see what your personal response is. And I do believe that you will learn faster if you're willing to make a decision. And obviously it's a lot less stressful than your clinical practice. So don't be shy in answering these polls. Good. Okay, so we're gonna end the poll, and we had some disagreement, and so some of that may have been the confusion about the sides. I apologize, but here you can see on the right side the normal hippocampus lying just medial to the temporal horn, and in this side you see no comparable structure. And so this is a patient with hippocampal atrophy. There may be a little atrophy of the fornix. You see the width, the transverse dimension of the fornix on the left side and the right side. So again, this would be a supportive finding, but the primary finding is the loss of structure here. Let's try another one. So again, this is the patient's right side. This is the patient's left side. And this is case two. And if you could decide on which side, if you believe the patient has mesial sclerosis, which side do you think the abnormality is on? Very good, very good. So again, a little disagreement, but the overwhelming agreement was that the left side. Now let's look at the left. Let's look at the left and right side. We'll start with the right side. Again, not high resolution imaging. Again, depending on your scan, although I have to say I've seen a number of scans that have been provided to me from Armenia, and I'm very impressed with the image quality I've seen. So obviously you have access to good quality imaging, and you should at your hospital either have, or you should be developing dedicated protocols to visualize the temporal lobes. And again, you want to be oriented perpendicular to the long axis of the hippocampus. You want to have your slice thickness on the order of not necessarily 1 millimeters, but I think probably 5 millimeters or less would be the ideal. And you can see here the normal hippocampus on the right side lying just medial to the temporal horn. Here's the temporal horn on the left side. Notice the small size of the hippocampus. It has a little bit of high signal, no loss of the internal structure, and a small fornix on the left side. So again, this is a case of left-sided mesial temporal sclerosis. All right, let's try another one.
Alex, if I can ask a question, this is Vika. Do you want to say a few words about an MRI with seizure protocol settings? Are you going to talk about it?
If you could, no, I'm sorry, you could just expand on that a little bit, if you can.
We use, for example, the stroke protocol settings where we have DWI and so forth. And for seizure protocol, it will be a coronal view, specifically focusing on the temporal lobes with fine cuts and so forth, as opposed to, let's say, transducers maybe, or DWR and so forth. I'm sure you're using it. You want to say a few words about it?
But yeah, again, I can actually send you a list what I think are ideal imaging for epilepsy. But again, you want to do this T2 weighted thin section coronals. I think you should have flare imaging in axial and coronal, and the coronals need to go through the entire brain, especially in adult onset seizures. And you need some high resolution T1 weighted imaging, whether if you're using Siemens, it's MP Rage or the like, that would allow you to look for abnormalities in the white matter. So yes, I can expand on that, and probably easiest if I just send you what I think is an appropriate list of sequences for epilepsy. Thank you. All right, let's look at this case, and this will be our third question. And I want you to look at this case and decide whether you think the right side is abnormal or the left side is abnormal. So make a decision. All right, very good. And I'm happy to see you're all fast learners, or you already knew about mesial sclerosis, but excellent responses. And here you see the normal hippocampus on the left side. Here you see the temporal horn. And here on the right side, the hippocampus is small, kind of blurry. Now this enlargement of the temporal horn, some people will talk about that. I personally don't think that's a really powerful predictor, but it does make sense that if you have some tissue loss in the hippocampus, you may see a larger temporal horn, but by and large, not an important localizing sign in of itself. So again, this is a patient of right-sided mesial temporal sclerosis. All right, and I think this is the last case we have in the series. And I want you to look at these two images in this patient and decide if you think the patient has mesial temporal sclerosis and on which side. All right, very good. So the important.
Sorry, I don't answer.
Yeah. Wait, I'm sorry. Say again.
I cannot answer. Can you share the link?
This was. Well, I think it's. I'm sorry. I think I closed it already, but that's okay. I mean, this is a little bit of a trick question that I put in here, and so when you look at these images, you notice that here's the right hippocampus lying medial to the temporal horn. Here's the left hippocampus. It actually looks about the same size, but you've lost internal structure. But the important observation is there's something else abnormal here. And so the important thing here is not to get too caught up in this idea that you're looking at that in a sense, every patient with a clinical history consistent with temporal lobe origin, electrical studies that support that, they don't always have mesial temporal sclerosis. And this is a patient who has a ganglioglioma. And so the important observation is to decide if you see evidence of mass effect, if you see abnormal signal that extends outside of the hippocampus, the patient does not have mesial temporal sclerosis. And so the tumors are often these low-grade tumors like DNTs, gangliogliomas, low-grade astrocytomas. And occasionally you're going to see cavernomas, and these will, of course, have blood products. So again, not everyone with temporal lobe origin epilepsy has mesial temporal sclerosis. So be aware of that and be careful not to sort of make the imaging fit a preconceived notion of what you expect to see. So here's another patient, has a temporal lobe origin based on clinical history, and I want you to decide on this one if you think that this patient has a normal scan or an abnormal scan. So again, maybe not fair, but I just wanted to have you make a decision about this. The important thing here is there's a little bit of signal here in the hippocampus here and here, but you see how bright this is on the T2 weighted scan. You would never really have that much signal arising from the hippocampus on a T2 weighted study. As an aside, the mammillary bodies are symmetric and so on. This is a patient with a DNUT, and the DNUTs often have this quality of being very high signal intensity on T2 weighted imaging. So again, if it doesn't have all of the typical features of mesial temporal sclerosis, and you don't see a small size of the hippocampus, you want to be skeptical about that diagnosis of MTS. Another one, this is gadolinium enhanced. You can see this enhancement again is you would never see with mesial temporal sclerosis. Here's a 50-year-old patient with new onset seizures. And what you notice here on the shallow flip angle gradient echo scan is all of this signal loss. This is susceptibility effect. We have a little bit of enhancement here. We have a dark rim on the T2 weighted scan. This is a typical appearance of a cavernoma, which is adjoining the hippocampus. And so this may look, for all intents and purposes, like a mesial temporal sclerosis case, both clinically and electrically, but this is these seizures are going to be related to the cavernoma. Now, this is important because this has a different surgical approach and a lower likelihood of successful surgery than patients with mesial temporal sclerosis. Here's another patient. Again, is this MTS? It's not in the hippocampus, right? This is the anterior temporal lobe. You see its high signal intensity on the FLAIR and the T2 weighted scan, and shows some enhancement after administration of contrast. This is another ganglioglioma. So these are these glioneuronal tumors, very common source of seizures when they occur in the temporal lobe. So you saw, I showed you some gadolinium enhanced studies. Should all your patients get gadolinium? And my response is no, that the vast majority of young patients with epilepsy should not get gadolinium. And this has been, there's articles that support this in the literature. And why do I say that? Well, if the patient has a brain tumor where gadolinium might be helpful, the imaging findings will tell you the patient has a brain tumor on the non-contrast imaging. And so you can always bring the patient back for gadolinium. And so you don't need to enhance, 100 patients to find the one patient who has an enhancing brain tumor. Just bring that one patient back when you see something that's suspicious for a neoplasm. And the second reason you don't want to give gadolinium is that iodine-based contrast and gadolinium-based contrast slightly decrease the seizure threshold. So if you have a patient who is prone to have seizures and you give them contrast, there's a chance, small, but there's a chance that you will incentivize or propagate a seizure of a patient inside your MR scanner, which is of course quite undesirable. So again, I don't recommend contrast as a routine in young patients. Now again, different in patients, older patients that come in with, let's say, someone my age with new onset seizures, yeah, of course, you're looking for a brain tumor in your differential, and by all means, give contrast. Now, some of the pitfalls that you will encounter in looking at the hippocampus, the most common one you're going to see are cysts, and I'll show you this case. You see this area of T2 prolongation in the medial temporal lobe. It has no restricted diffusion. In fact, it looks like CSF on the diffusion scan. It looks like CSF on the FLAIR scan, doesn't enhance. And you can see it lies here along the choroidal fissure. You can see this is the choroid plexus here. And so the differential in this location is going to be a giant perivascular space, but the orientation here, I think, would favor a choroid fissure cyst. But these are benign cysts that occur in the region of the temporal lobe and do not ascribe to these any clinical significance in terms of representing an epileptogenic focus. These are so common in the population that when they occur in a patient with epilepsy, they can be mistaken for significant pathology. So again, in this location, choroid plexus, choroid fissure cyst, and here's another, this is a very large choroid fissure cyst. You'll notice it's very bright, so it's easy to find. You see its relationship to the hippocampus, but you notice it suppresses completely on the FLAIR scan. There's no surrounding T2 prolongation. So again, this is a large choroid fissure cyst. Here's another one, same location, medial temporal lobe, right? Here's the hippocampus on the other side. If you look at this T1 weighted scan, you might say, well, it might be a choroid fissure cyst. There's no enhancement. But if you look on the FLAIR scan, you see all this signal abnormality here. This is not consistent with a choroid fissure cyst. So you have to be very rigorous in your application of these rules. So while in some respects it resembles a choroid fissure cyst, this is not a choroid fissure cyst. This was a DNT. So again, there is an overlap in some of the pulse sequences, which is why, as you know, with MR, you have to develop a story that explains the appearance on all of the pulse sequences. So obviously, if this was a choroid fissure cyst or a giant perivascular space, it would suppress completely on the FLAIR scan. Now, another common finding that you'll see in the hippocampus, and you see the way it lines up, there reminds me of like peas in a pea pod. You can see 1, 2, 3, these cysts along the hippocampus. You see this high signal intensity here, high signal intensity here on the coronal imaging. These are benign hippocampal cysts. These may be degenerative in nature. You rarely see them in children, but this is not to be mistaken for pathology. Now, one thing I want to draw your attention to on this image, you might say, okay, what about this hippocampus? And I see a thinner fornix on this side than this side. Now, I didn't get into this in this talk as an introduction, but this is something that we published years ago, is that the fornix can be smaller on the side of the bigger ventricle. As you know, ventricular asymmetry is very, very common. And so the fornix can look stretched on the side of the larger ventricle. So this is not an effective localizing finding in patients with asymmetric ventricles. So again, this is another pitfall. Don't get caught up with this, is assuming that this is an indication of a localizing find for epilepsy. Now, this is an important case. I want you to pay attention to this. This was a 30-year-old had a fall, had a CT scan where they found a cystic structure, and went on to have an MR scan. And here on the MR, you see this space which suppresses completely on the FLAIR imaging, but has some surrounding T2 prolongation. Now, this scan was done at the time of presentation. This is 1 year later. Now, the reason that we were following the patient is that the clinicians suspected this was a cystic brain tumor. But what I want you to be aware of is that this is a very specific finding. If you've never seen it before, if you're not aware of it, you're going to mistake this for significant pathology. But this was published in 2013, and they noticed this phenomenon. And I've seen it in my own practice. Unfortunately, one of these went on to biopsy, which was unfortunate. But this is basically a giant perivascular space. But when they occur in the anterior temporal lobe, and this is an illustration from the paper, they have this quality of T2 prolongation for reasons that are not entirely clear. So here's one where there's no signal abnormality. Here's one where there's some signal abnormality. Here's one and another where there's quite a bit of signal abnormality. So be aware of this, that these giant perivascular cysts, when they occur in the anterior temporal lobe, can have T2 prolongation. Now, for you as a radiologist and neuroradiologist, how can you handle a case like this? Or to put it in another way, how can you be sure that this is not a low-grade neoplasm? And my response would be, okay, it's fine to have some degree of uncertainty, but if you're going to advise the clinicians correctly and help your patients, I think the best thing to do in circumstances like this is to just indicate that this can be a benign phenomenon unrelated to the seizures. And I would say the best thing to do in cases like this is to just follow them for maybe you want to pick a follow-up in 6 months, because if you're thinking it's a low tumor, it's going to be low grade. But I think the best thing is to just follow these patients. Do not recommend biopsy or any kind of aggressive treatment because of the high likelihood this is a benign finding.
I have a question, dear.
Yes, Kostan.
So why don't you think that it might be something, for example, post-traumatic or something like that? Because the gliosis is not small, the zone of gliosis. Do you agree with me?
No, I think that would be quite reasonable and could explain some of that. Although, to my knowledge, and in the cases that I saw, there was no real history of trauma, and there was no like encephalomalacic change elsewhere. But I think as long as you are open to the idea in your reporting of these, that this could be unrelated to the seizures, and that this is a reported benign finding, then I think it puts the clinicians on the right track. But yes, there could be an overlap in imaging with this appearance and the consequences of trauma with the vulnerability of the anterior temporal lobe in trauma cases. This is a good point, Kostan. Thank you. Now, this is another uncommon entity that you should be aware of. And again, I think that I counsel my residents. I've sort of been on a rampage about this for the last few months. I work at a hospital where we have this population, and many of you may have noticed the same thing. We have this intermix of a fair number of very routine cases with some extraordinarily rare cases of odd diseases. And you need to be aware of the appearances of unusual diseases, because there is a tendency to accept things as all variations of common disease. So perivascular spaces are very common, but this one turns out to be a very specific appearance, these multiple cystic areas in the subcortical region that don't suppress on FLAIR imaging. It doesn't really look like a neoplasm, but neither does it look like a routine case of giant perivascular spaces or attached criblé. So this entity has a name. And this is kind of a long one, but multinodular and baculating neuronal tumor. But the important thing to recognize, this is a leave me alone lesion. Now, can this be associated with seizures? There is some indication that these may be associated with seizures, but but when you see this kind of like a multicystic lesion, subcortical with non-suppression on flare, don't classify it as some sort of odd variation of giant perivascular spaces. This is another phenomenon that I want you to be aware of in the setting of epilepsy, that while we look for signal abnormalities as the cause of the seizures, you can also see abnormal signal as the result of seizures. Many of you may have seen this in your practices, your MR practices, but when the patients present, in this case, this was a patient with status epilepticus, that you can see this diffuse cortical restricted diffusion at the time of seizures. If you image them close to the time of seizing or even while they're seizing. And here you can also see this abnormal signal in the thalamus, which may be part of this excitation in the circuit of Papez, because remember the thalamus is part of that pathway. So this phenomenon of signal abnormality as a result of seizures is important for you to say, while this could be the source of seizures, perhaps, it's a less extensive involvement and maybe you're thinking it was a stroke that led to the seizures, but don't, mix it up in terms of like the chicken and the egg. You have to be cautious as to whether you're looking at the cause of the seizure or the effect of seizure. So you need to investigate in these cases when the patient had their seizure relative to the time of the imaging. Obviously, if a patient like this had not had a seizure, for months prior to the imaging, then you would approach this quite differently. So another pitfall is that the small hippocampus is not always the result of, or not always diagnostic of, this mesial temporal sclerosis. And so you can see a small and abnormal hippocampus in patients with anoxia, carbon monoxide poisoning, and as I indicated, in status epilepticus. But you'll also see involvement of the hippocampus in herpes simplex, in this entity of limbic encephalitis, and in posterior circulation infarcts. So I want to introduce this terminology you may or may not be familiar with. It's this idea of selective vulnerability. And this term explains a concept that explains why a diffuse insult, for example, cardiac arrest, near drowning, drug overdose with anoxia, while it affects the entire brain, you may see an isolated injury to the hippocampus and other structures like the cerebellar gray-white junction and sometimes the basal ganglia. So this explains why in patients of anoxia, like here's a patient in my practice who had a minor procedure, was sent to the floor after conscious sedation, but had a respiratory arrest on the floor, was resuscitated and recovered. But when we had some memory issues and when we did image the patient, we saw this abnormal restricted diffusion in the hippocampus. And just last week, I saw a case of heroin drug overdose with resuscitation with bilateral hippocampal abnormalities. These are very likely the consequence of this phenomenon of selective vulnerability, and it may or may not be associated with basal ganglia abnormalities. Here's a patient, this is a sequela, in this case of herpes simplex encephalitis. Remember that is a neurotropic virus and tends to involve specifically the medial temporal lobe. And this is what the patient looked like at the time of their infection. And you can see the abnormal enhancement, which occurs in the subacute phase involving the medial temporal lobe and also the bilateral insula, which is a common pattern of involvement. This was a case sent to me by a friend of mine, Dr. Mancall. This was a patient was found by the side of the road in his car. The patient was confused. The police brought him to the hospital. He maintained this disorientation. They got an MR scan and they noticed this expanded abnormal hippocampus And then 2 months later, there was involution of the hippocampus. So again, this is not a case of mesial temporal sclerosis. This patient found they considered limbic encephalitis, and the patient was discovered to have an underlying lung cancer. So limbic encephalitis is one of the paraneoplastic syndromes that has a brain representation that manifests itself in the temporal lobes. It can be unilateral, it can be bilateral. And from an imaging point of view, it's actually quite difficult to discriminate from herpes simplex encephalitis. So I think at the time of presentation, you want to consider both of those, but usually with titers and so laboratory studies, they can usually exclude herpes and will leave you with the diagnosis of limbic encephalitis. Remember that not all patients have a known cancer, but if you see this pattern and you think it's limbic encephalitis, it's very reasonable at that point in time to look for an underlying cancer. This was a patient had a minor procedure, was difficult to arouse, and this patient had a visual field defect, and you notice this involvement of the hippocampus. This is an example. This is a posterior circulation ischemia. Remember, the hippocampus is a part of the posterior circulation. And so here we see this infarct of the occipital lobe and the hippocampus. And it shows you actually very dramatically, coming back to terminology, the word hippocampus comes from the seahorse, and it gives you this kind of seahorse appearance you see here from this restricted diffusion. Here's another patient with multiple posterior circulation infarcts involving the cerebellum, the midbrain, and here you see bilateral hippocampus involvement. So my point is that not everything that involves the hippocampus is mesial temporal sclerosis. So again, in terms of the top things to be thinking about, the benign entities are the cysts, and the other possibilities, think about vascular disease and paraneoplastic disease, as well as infectious disease. In this last few minutes, I want to touch briefly on congenital brain abnormalities, which may be more relevant to some of you that see a pediatric population of epilepsy. And so I'll touch on these topics of heterotopic gray matter, cortical dysplasia, band heterotopias, which is a migrational abnormality, and we mentioned cavernoma. Heterotopic gray matter is best seen if you look at the periventricular region as a common location, but you especially want to look in this area lateral to, in this case, the atrium and proximal portion of the temporal horn. You see this tissue that lines the lateral portion of the ventricle, and I tried to illustrate for you in those cases that there should be no gray matter lateral to the temporal horn. However, the way you can discriminate this from, say, neoplasm and other structures is that signal will follow that of the cortex. So this is a migrational abnormality. When these areas of heterotopic gray matter are adjacent to the hippocampus, they can be a source of seizures, although any heterotopic gray matter is suspect that they may be involved in the seizures. So look for, this is one of the things you're going to be looking for on your scan in patients who come in with a non-localizing intractable epilepsy. Here's another example, a little more subtle on this scan, but you can see this lumpy appearance of the lateral border of the the lateral ventricles. And this is another example of heterotopic gray matter. Now, this is a more difficult diagnosis here, and it requires you sort of having a good understanding of what the scans should look like. But in this case, you'll notice that there seems to be the signal of white matter, and then this band of tissue that lies in between. And I'm showing it to you because, like many things in radiology, it's easier to recognize if you've seen it before. But this is very easy to miss, but this is called a band heterotopia, and this is an arrest of neuronal migration, can be associated with seizures as well. So be familiar with some of these patterns of migration abnormalities. Now, this is an example of cortical dysplasia. Not all cortical dysplasias have a T2 abnormality, but this one does, and this is one of the patterns that you'll see. But you notice the cortex looks thicker here. We have this tongue of abnormal T2 prolongation that extends to the ventricular margin. There can be some venous anomalies as well, but this is an example of cortical dysplasia. These can be confused with low-grade neoplasms, and there is some overlapping appearance. Sometimes you need follow-up and some advanced imaging, if possible, to sort it out. A good example here of what I'm talking about: when you're imaging, as part of your imaging sequence, you want to have a high resolution technique, like this is MP-RAGE, where you can see very clearly the white matter, the cortical ribbon of the brain. This is going to allow you to identify areas of thickening in the cortex, areas of abnormal heterotopic gray matter. Here again, you see the normal temporal horn and the white matter that abuts the lateral border of the temporal horn, and the normal appearance of the hippocampus bilaterally with that wavy appearance of the anterior hippocampus. So this is a pulse sequence that you want to have as part of your workup of the patients with intractable epilepsy. Another case of epilepsy. This one shows what's called malrotation of the hippocampus. Here's the normal orientation of the hippocampus. This one is oriented more vertically, and this is one of the pediatric thought to be causes of seizures. So I'm showing you a lot in a little bit of time. This is one of the limitations of a course like this, is I can't show you everything, but I want to touch on some of these other categories of disease and make you aware of the sort of imaging that's going to help you in establishing where there might be an epileptogenic focus. This is the case of closed lip schizencephaly. Schizencephaly is not strictly a migrational abnormality. This may be the result of an in utero insult, such as an infarct or a hemorrhage. And so there can be this band of of fluid that extends from the outer surface of the brain all the way to the margin of the ventricle, with this peaking that occurs. You see this abnormal contour of the ventricle. This may require some high resolution to identify. The hallmark pathologically, this is on sort of that autopsy of a schizencephaly, is what's called the pial ependymal seam, that if you follow the ependema, it merges with the pia of the brain at some point. And so then again, this is a sort of a slot that extends. You may see the CSF all the way across. In this case, you may not, if it's a true closed lip, look for this contour abnormality in the lateral border of the ventricle. So that's all the material I'm going to show you today. I know I covered a lot. I want you to be conscious then of the fact that you need dedicated epilepsy sequences to allow you to identify an epileptogenic focus in patients with drug-resistant epilepsy. Remember that your approach to imaging is going to be different depending on the timing of the onset of the seizures and what you suspect as a cause of the seizures. And as I've touched on here, there are a broad variety of causes of seizures, and there are some things that are commonplace in imaging that when they occur in patients with epilepsy can be mistaken as a cause of seizures. So I want to make you aware of some of those so you don't overemphasize them in your reporting. The one thing I didn't touch on, just to mention that, are developmental venous anomalies. These are also very common in the general population. And when they occur in patients with epilepsy, I would caution you to predict that these are causal in the seizures, in a sense, an epileptogenic focus. But cavernomas are often associated with developmental venous anomalies. So if you see a DVA, look for an underlying cavernoma, as I talked about. Well, that's a lot. And I want to thank you for being punctual and joining me today. I'm happy to take any questions at this time, or if you prefer, you can email questions to me.